questions for.
Oh, and I want to ask those of you that have questions to make sure you introduce yourself before asking the question.
Hi, Federico Monzon from Invite. Dane, I also really like the transitional section, but I did wanted to, you asked the question, should we actually, pay for panels that do more than what, your intended use is at the time? And my suggestion would be, yes, you should. And the reason why I think it's history shows us already why that is valuable. And I think that would lead to very useful clinical information. When we started doing microarrays, right, for germline disorders, we started with the question, should we do focused microarrays for very specific diseases, or should we do, with genome-wide microarrays? And very quickly, it was shown that by doing genome-wide microarrays, we started uncovering many disease-gene relationships that we didn't even know existed, right? And even, phenotype, genotype correlations that ended up being very useful in the management of those patients. I think the same has happened already with the example of lung cancer that was shown before, right? If we had just decided to do EGFR and ALK, we wouldn't know of ROS1, we wouldn't know of KRAS mutations, we wouldn't know of all of those other mutations that are there, right? And yes, those have been done and found on a research environment, but when they're done in a research environment, we lack the clinical correlation. So I think, if we allow that to happen, then you will have a very, very useful tool with clinical correlations. Not only that, you actually have the power, maybe, for somebody who's doing a very wide test, right, to say, I will cover it if you release that data into the public domain so we all benefit from it, right, rather than just the patients who have testing at your site. So, I think it's a powerful tool.
You're speaking exactly what we're thinking as well, particularly when it comes down to it. When you start looking, what's the cost effectiveness of running gene panels? And we recognize that there's great value in doing things like next generation sequencing or other techniques where you can use much lower data sampling, requirements. You don't have to chew it up. You don't have to rebiopsy patients. And so what has to happen is there has to be an understanding of a controlled method that is used in data collected. Because what happens is if we go through and all of a sudden immediately cover everything, and then what happens when we are going to get to more complicated disease states? And so there's got to be a way of saying, look, when we cover this, and this is what you're going to likely see, from the MolDX program, is we're going to use coverage with data development, but we're going to say this is how we'd like to see it done in a very staged method of using these new genes that come out onto the marketplace. There are specific things that Medicare cannot pay for. Medicare cannot pay for things that are purely experimental. And so at what point do you start saying, I've got enough litmus of information that I can now start covering that, and then I get the added information for free? I mean, we're probably almost there in non-small cell lung cancer. We're probably not there in a lot of other disease states, but we will get. And so, that molecular evidence development consortium that we're talking about, part of the reason why we've proposed that is it is a method to do exactly what you're talking about doing.
Thank you.
Okay, next question.
I know the solution. Catherine Phillips, UCSF. CPT codes. So there are new CPT codes coming out for, you knew I was going to ask this, for panels and for sequencing. Now, just because something has a CPT code doesn't mean it has clinical utility. However, one of the major barriers to payers has been that they can't tell what tests are being done, when, how, on whom, and what are the outcomes, because there was no coding that enabled them to actually track in databases what was being done. So with the advent of the new CPT codes, will that help payers get a better grasp on what's being done and therefore be able to determine the clinical utility?
I can truly say I'm not the CPT guru. That's Dr. Jeter, thank heavens. But here's the concern, is every disease is different. And because every disease is different, the new CPT codes look at, I can pay up to 5 genes and 5 to 50 genes. And the answer is, do I need 5 genes in colon cancer? Well, I don't know. How about 5 genes in melanoma? Maybe. I mean, it's one of those things where do you make the distinction between, the number of genes and not? Second thing, which is probably more important, is how do I know that every lab that is ordering that panel has done it the exact same way. We've already heard from several different people that there is a great deal of variability in panels, and there's a great deal of variability on how that information is being obtained. And so what the MolDX program has proposed and what was in the recent legislation of CMS is that there should be individual HCPCS code for each, or something like that, for each individual test. And the reason why is we believe that each individual test should be covered as an each individual test, because that way we can know what's going on. Now, is it a perfect system? No. But one of the things that we've got to do is we've got to work our way through it. And I think the new CPT codes was a step forward, but it probably doesn't address the payer's needs yet, because it's something that is too complicated to say I'm going to bucket it into 5 or 50 or 200 or whatever the number is. But it's a step forward.
So if I can just, oh, there we go. I think the coding helps payers to know more accurately what they're paying for. And to the extent that they have done assessments of utility of the things that they're paying for, then that would give them more confidence that those things have utility. But ultimately, it's the evidence reviews they do that tell them whether or not things have utility, right?
So I had 2 comments and a question. So the first comment is that at least in the lung cancer, Bruce Johnson from Dana-Farber, the first comment I have is that none of these agents that either have an approval or are close to an approval in lung cancer were discovered by next generation sequencing. They were all by hypothesis generated and old-fashioned research. The ALK was discovered by transfecting DNA into NH3T3 cells, which is something I used to do as a postdoc. So it's a long time. So that's the first thing, that the next generation has not been terribly effective at discovery for clinical useful tests. The second one is that, and this is the question that I would pose, is that, and this has been commented on, and the multiplex test directly informs this, and one that we worked on, and that is that, do you think we should be going through each disease, and when the cost of doing the test exceeds individual tests, that then the multiplex test is then approved? So for instance, in lung, if you've got 4 genes, BRAF, ROS, ALK, and EGFR, where the individual test would be more expensive than the multiplex test, should it be approved? And then, what about melanoma, where you have BRAF and c-KIT? Should that be approved? Do you have to wait till there's 2 more? So that's the question I'd like you to comment on.
So every panel is disease specific, even though it's probably the exact same panel you're running in your institution. I mean, so this is our next gen sequencing panel, or whatever it is. My multiplex panel, and this gets back to that or to the new HCPCS or the new CPT codes, which basically said handle all these 50 genes, and none of them probably related to each other in a great way. They're groups of genes in multiple disease states. And so I would say in general, when you get to a point where you're looking beyond 3 genes, it does make sense to start looking to newer technology, because it becomes cost effective at that point. But there's a big caveat, which is, now what do you do with the companion diagnostic question that the FDA has just raised? Are we absolutely sure that the increased sensitivity of the newer technology can translate to also better clinical utility? It's kind of like when they changed ER positivity from being 10% or more was ER positive, and now it's 1% or more. I mean, clinically, we know that a patient with 2% ER positivity is going to respond differently to tamoxifen than a patient with 10 or 15 or 50% positivity. And so it goes back to this idea that, yes, we believe that newer technology has great potential, but we've still got a major question, which is, what do we do with making sure that the increased sensitivity also does translate into better outcomes for the patients with the newer technology?
The last comment I would have, and one of the things I'd urge people to think about, is that in our hands, the greatest clinical utility of doing a next-gen platform is never having to go back and retest the patient's tumor. So for instance, if you end up finding a BRAF mutation, and you eventually want to find out, does the person also have you find out then that the loss of P53 or the loss of LKB1 informs whether the person is or is not going to respond to that agent, that you don't have to go back and retest. And that's one of the things that I think would be of great urgency when thinking about this, is to look at how many times you can spare yourself of having to go back and do another test as you go to 2nd and 3rd line treatments on these patients.
Okay, any other questions? I think we're right at the 2 o'clock hour, so we can begin our next session. Thank you.